Thank you. Thank you. Good evening, and thank you very much for the opportunity. Over the next 10 minutes, we will look at the surgical management of thymoma and thymic carcinomas. Dr. Rajiv has very nicely brought about the pathology, because pathology plays a very important role in your decision making regarding the role of surgery. I will not get into the slides again. But just for the next few minutes, I will take you all through what thymoma is all about and what is the role of surgery. Are my slides moving? Yeah. So thymoma is the most common anterior mediastinal tumor, and we know that it constitutes about 20% with an age common between 40 to 60 years, and male to female preponderance is about 1:1. The most common presentation that we see are either because of an incidental diagnosis on routine chest X-ray, you find a mediastinal mass and then you pick it up and then further evaluate, or local symptoms. Unfortunately, the tumor must have been very aggressive by the time, and paraneoplastic syndromes. There are multiple paraneoplastic syndromes where myasthenia gravis is the most common paraneoplastic syndrome seen. Diagnosis, CT is the gold standard. A good contrast enhanced CT is the gold standard. It based on the radiological findings, you would actually identify anterior mediastinal masses, and most of the times a biopsy is not required to go ahead with the management for well encapsulated. But if you have any suspicion that it's not looking like a thymoma, or you have a borderline or an inoperable patient, then a biopsy is mandatory. MRI is very rarely indicated, only in the upper when you have loss of planes with brachiocephalic, or you want to do extensive, you're doubtful about the indication. And role of PET is controversial, wherein most of the things can be picked up with the CECT of the thorax and the upper abdomen, even with the metastatic sites, if at all, because you mainly want to rule out an extra pleural disease. So now coming to the treatment, we have stage 1 and stage 2. Undoubtedly, we know that the treatment of choice is surgery. For stage 3 and stage 4, we will still look into it. Surgery still remains, but with some form of multimodality treatment, which will be covered in the next topic. So the extent of surgery, there's always a debate whether you should do a total thymectomy or a partial thymectomy. So what do you mean by total thymectomy? Total thymectomy is removal of the entire fibrofatty tissue of the anterior mediastinum. That's the entire thymus gland, along with the 2 cervical horns from phrenic to phrenic, and the entire fat reaching till the diaphragm. So this is a total thymectomy. It is possible, and partial thymectomy is another option. When you should do. So for a patient with myasthenia gravis, there is no role for partial thymectomy. But it is feasible in patients those are non-myasthenic, because it has shown no difference in survival or recurrence rates. And also the rates of developing myasthenia later is also similar. Of course, the first and foremost thing that we need to remember here is there are no randomized controlled trials in this disease to say that this is better or that is better. Most of the series comes from the retrospective series, and the largest is one of the series from Japanese series. So now coming to thymoma and myasthenia, we know that myasthenia is seen about 50% of the patients with thymoma, but only 10% of myasthenia have thymoma. This is something which we need to remember. And surgery for myasthenia gravis, that is thymectomy, is not an emergency surgery. Patient should be adequately controlled with drugs, with pharmacotherapy, before you take up the patient for surgery. This is something which I want to stress upon. Then, regardless of the antibody status and myasthenia type, in thymoma, if there is a thymoma, surgery remains a treatment of choice, and definitely it reduces the pharmacotherapy. However, in a non-thymoma, the surgical treatment purely depends on the antibody status, whether it is generalized or ocular, and the patient's age. So this is a very interesting chart which I've taken from UpToDate. So once you confirm the antibody status, and then the initial evaluation and management, as I said, is with pharmacotherapy and with AC inhibitors with or without for control of symptoms. And then let us say if it shows thymoma, go ahead. If it does not show thymoma, look for MuSK or LRP for antibody associated myasthenia. And depending on whether it is yes or no. If it is yes, then there is no role of thymectomy. If not, or if the patient is having generalized myasthenia or an ocular myasthenia with debilitating symptoms, then the age factor comes into picture. Anybody less than 50, thymectomy would definitely help. More than 65, there is no role of thymectomy. And 51 to 65 is the age group where you have to take a call for thymectomy, but defer thymectomy as long as possible to continue response to pharmacotherapy and then take a call. So this is a very good flowchart to decide on patients with myasthenia gravis and those who are whether thymectomy would help or not. Now, what is the surgical approach do we have? Median sternotomy by far is considered the gold standard and to achieve access for both thymectomy as well as extended thymectomy. But what is the problem? The inadequate surgical access sometimes to the upper and lower chest if you have extensive disease. So for these structures which are involving hemiclamshell is a very useful approach wherein when they involve the adjacent structures. So this was first reported by Masoka for cervical as well as mediastinal or cervicothoracic. And when it invades the great vessels in the neck, so such as a brachiocephalic or a median sternotomy with transmanubrial osteomuscular sparing approach is also useful to achieve a complete resection. So is minimal invasive surgery for thymus safe? What are the approaches? We can either approach the thymus. Generally, the golden principle is approach the thymus from the thymectomy, where the thymoma side is, because you have a good control. But in case if there is no thymoma, the choice is definitely left whether you want to approach from the right side or left side. And it is surgeon's choice. And bilateral VATs, because putting a camera on the opposite side also helps you identify the phrenic nerve and preserve, because phrenic nerve preservation is something which is very, very important in patients with myasthenia. The other approaches are subxiphoid or a single port subxiphoid or a robotic thymectomy. The advantages with VAT thymectomy is generally carbon dioxide is used and it actually makes you help in dissection of the cervical horns, which actually makes it much easier. And you know that the recovery in these group of patients with the minimal invasive surgery is important. But mind you, the extent of surgery will not change whether it is a minimal invasive surgery or an open surgery. So similarly, whether robotic or manual invasive, there are no comparison trials, but then they found that lesions more than 5 centimeters are not appropriate for minimal invasive. But however, there are series which shows even up to 8 centimeters can be safely handled by means of minimal. And the other important thing which you need to take into consideration is avoid tumor rupture or capsular breach. So that unnecessarily upstages the tumor and you may have to give adjuvant radiotherapy. Unfortunately, the data may not be very strong, but then you are upstaging the patient if you cause a capsular breach. So extended thymectomies, yes, feasible, possible when you have mediastinal structures involved. You could go ahead and do a pleuropneumonectomy if required, reconstruction of the SVC or the brachiocephalic, or depending on whatever have been reported safely by several authors in this group. And the key for surgery is to achieve an R0 resection. So for patients who are locally advanced, you use the extended surgeries, but after some form of neoadjuvant chemotherapy, wherein you would have a role for cytoreduction or debulking the tumor and then taking a call. So aortic arch involvement, these are others. So, and remember, when phrenic is involved, do not try, and when it's grossly involved, it needs to be, but also make sure that you take care of the diaphragm so that to improve the postoperative pulmonary function. Now, recurrent diseases, there are no standard guidelines to what exactly should be done, but from, the recurrences were about 14.8% from one of the series from Japan, and most of them are pleural. So recurrence diseases, whenever and possible salvageable by surgery, should be salvaged because they are known to have a better prognosis when compared to not doing anything for this group of patients. So how do you manage pleural disease? So most of the times, thymomas and thymic carcinomas with high rate of locoregional and tend to have very poor prognosis. So the 5-year survival rate is about 53 to 87%. And the treatment in this group of patients is very controversial. So the most important key is maximal tumor debulking with aggressive local therapy could offer, and also systemic therapy for sure. Despite that, your recurrences are very high, and combination of cytoreduction with concurrent chemoradiotherapy or is the gold standard as of now. So there is a new kid in the block, let's say hyperthermic intrathoracic chemotherapy. The role is not very clear, but there are additional studies which have looked at the basic principle is the local therapy. The chemotherapeutic agents are high doses can be achieved with minimal absorption. So systemic effect is less. But however, Macroscopic complete tumor resection is the key, and cisplatin-based regimens are more commonly used. It has shown some promising survival and disease-free survival in low-risk epithelial, malignant, pleural mesotheliomas. But its role in thymic tumors is still controversial. So these are some of the studies where they have looked at, and they have shown a promising recurrence-free as well as survival, overall survival. But mind you, the number of the patients will always be smaller numbers because this is not that common. So the perioperative outcomes are not different. They show that pleural, the toxicity related is about, postoperative renal fail is predominantly depend on the cisplatin dose. But however, the other morbidities like in-hospital mortality and the outcome is more or less similar, but definitely needs more robust studies. To conclude, surgery remains the primary treatment of choice for thymoma and thymic carcinoma. Maximal cytoreduction is the key in advanced stages. Avoid tumor spillage in early cases. It definitely worsens outcomes. Surgical CRS with HITOC offers encouraging survival rates, but cannot be done outside experienced centers. It has its own morbidity. Both primary and secondary, that is pleural recurrences, stage 4 should be offered surgical treatment at some point of time whenever operable. Safe and feasible in selected patients with thymic malignancies and pleural dissemination. Thank you, and I would be happy to take any questions.